because the way that we recognize the degree of deep folds, it just depends on the information from our eyes. I already said surface anatomy. The information is affected by the shadow from this gap. In order both patients and doctors to feel the improvement of the fold, we should reduce the gap. Raising the lower aspect and lowering higher aspect. Here are the solution. Lower the higher aspect with absorption or lifting to flatten the folded tissue. And raise the lower aspect with feeling something, both deeply and superficially. Deep injection is to restore volume, and superficial injection is to detach muscle from dermis. One of the composition of first subunit is mixture groove. It's exactly different from tear-tube ligament. I think this line is most difficult to notice and predict before procedure. That's because there are many cases that the groove hides behind too loosened skin. It's like something behind a curtain. Occasionally, we can't know its existence by the loose curtain. The curtain camouflages it. As I already showed to you, you can meet like this case. The blurred mid-cheek groove by loosened skin. Okay. The medial side of the cutaneous ligaments can be tight by lifting. So, to avoid this situation, to scan and catch this problem before procedure is very important to avoid post-operative arguments. Last component of this unit is anterior cheek. Anterior cheek becomes flattened by fat deflation, especially deep medial cheek bend. We can change or improve this area by lifting. Thus, some additional procedure is needed to improve first subunit together when we proceed thread lifting. She got a conventional facelift, but as facial contouring and facial shape is improved, but the anterior cheek part never changed. This combination procedure connects to how we eventually can get back youthful face. Kids and teenagers have convex midface with tight skin and fully filling. With aging, we lose both them. Midface gets to be concave and the hidden line by ligament is revealed. Lifting is effective in reducing the space to fill, but not enough. So I recommend combination lifting and fill. These compartments, infrofrontal fat, superficial medial cheek fat, and medial soup, deep medial cheek fat, are targets to fill. This is my sequence to inject filler in the first subunit. The needed amount of filler is not today's point. To improve first subunit, we should manage 3 components all together. It's important. For that, I do lifting and filling simultaneously, and I recommend to you. Then second subunit. Here's relatively simple than first subunit. Do you think sagging deepens the marionette line? Many doctors and many patients think like that, so lifting makes them better than before. I agree, but in particular, then I say particular, then what proportion will be affected by tissue sagging? How proportion? I'm not sure, but I think it is less than we expect. There are many cases to be improved by only filler injection on marionette line, then nasolabial fold, I think. Of course, lifting is one of the necessary procedures to improve, but we need to pay more attention to muscle in this area than nasolabial fold. Just to remember, three muscles, risorius and depressed anterioris. Modulus is not muscle, but anyway. Marionette line is mainly related to depressed anterioris. I guess marionette line is usually along the medial border of the DAO. Older patients tend to be in a basic state of applying strength to the DAO. They have like saddle face. In addition, Korean or many Asians has lower modulus line and resort line than Caucasian, and risorius loosens with aging. Loosened risorius and lower modulus are related to upper 1/3 of marionette line. So, lifting targets to improve loosened risorius. Modulus position change is almost impossible, or it is temporarily, even if possible. DAO is also can't be changed, so just detach muscle insertion from dermis and feel something between dermis and muscle. We play a role like a cushion to cover up so that it doesn't show the movement of muscle on the skin. Buttocks is also useful. I use combined, or buttocks, lifting, filler, everything to improve. This is a very severe case. I did all, as I already mentioned, fat lifting, filler, buttocks, but you can see, you can see it's improved. But, okay, it's improved, but limited because of her habit using, the habit of using GAO. To summarize about second subunit, sagging jaw fat around risorius muscle should be lifted. Sometimes I also do liposuction and then inject filler just under the dermis for detaching the muscle from the dermis. There is no firm and stable structure to raise the lower aspect compared to nasolabial fold, so I just inject filler superficially, just under the dermis. Last subunit is more simple, but most important to contour. The component of this unit is only one, lateral cheek fat. Lateral cheek, that is lateral cheek. Yeah. Can you just describe what is different between the pre and post-operative pictures? Can you see? Just there is difference. Is nasolabial fold or marionette line is also improved, yes, but the further thing that catches my eye is the change of the facial shape. Her face looks square and long before procedure. After the procedure, her facial shape is close to circle, like kids or teenager. Let's take a look at another case. How about facial outline of this patient? Before surgery, facial outline is wavy and bumpy. The line between zygomatic arch and mandibular angle is a little straight, not convex. After surgery, the line becomes convex and her facial shape becomes closed circular. Right picture is post-operative, and we can also think this picture is when she was young. With aging, lateral cheek fat, especially in deep layer, deflates and it leads the shell on the fat compartment loosens and distends by gravity. This makes patients lose mid-face fullness and causes smaller hollowness and relatively noticeable zygomatic arch. I think this subunit is most relevant to the contouring effect. Often we can also meet like this patient. He has a severe smaller hollowness by hard zygomatic cutaneous ligament, lateral zygomatic cutaneous ligament. It's difficult to get contouring effect by lifting. In this case, we should find another way to fill in smaller area, but it's not fully work. I think there are cases who has limits, of course. For like this case, I will just give you a tip. Many doctors just consider HA filler only to fill somewhere, but the filler can spread to another side or move to. Thus, I often feel like this. Combine mesh thread and filler. Connect the thread cannula to filler syringe. I already punctured targeting site. Just insert. After that, fill. I think I inject filler. No. I think mesh works as scaffold to keep filler in a limited area. You can also think this to use at an anterior cheek and nasal board also. Just a tip, try it. Very useful, very effective. To the next, I'll talk about my thread lifting technique and my own principles for contouring effect. This sentence is in the same vein as I mentioned at the beginning. If you focus on too much in detail, just line, just fold, you can miss something big. Patients want to look younger, not just to disappear some wrinkles, but they express or say, I want to eliminate this fold, everything. Yes, we can do it. We can make it using much amount of filler. But are they satisfied? Or have they been satisfied? If we do like that, they will come back to our clinic and ask us to melt them and fill again, melt them, fill again, as it's gonna be in a vicious cycle. We are some kind of translator. We should know to read out the hidden meaning from their words. And then we should persuade them to follow us. I explain my patients, aging has a sequence, like crossing stepping stone bridge. In the same way, for natural anti-aging effect, we should head back the way we came. To restore sagging and skin laxity with lifting is first. Then to restore bone resorption and fat deflation with filling is next. Lifting is especially more effective to reposition sagged fat tissue than to tighten loosen the skin, I think. It is similar to pick up and lifting fruits with a toothpick. Pick with cork thread and pull up this sagged fat compartment. For this process, lifting can improve facial contour. And I'd like to mention that facial contouring is a three-dimensional change, not two-dimensional. This should be our ultimate goal. Of course, we can recover a patient's fullness by filling only, but it will make a big face like moon. Considering aging sequential process, it is reasonable to fill as much as it is insufficient after lifting is done first. Even without any filling process, we can get contouring effect through only lifting, of course. But more invasive surgery is sometimes needed to severe cases like this. Very heavy, too heavy to lift by thread sometimes. Now let's apply the theory clinically. Many doctors now might think, so what do you mean, what do we do? How? So remember this, accurate targeting. When you insert a thread here from there, you should have accurate reason. You should have an accurate goal that you want to get from the procedure. Even only one track. And I recommend to use multiple entry points and insert thread overlapped each other. Accurate targeting is related to inserting depth. We should insert between subcutaneous and superficial fat to hook subcutaneous fat and superficial fat. There is a quick loosen space. We should target superficial fat compartment than deep fat compartment. This is the reason why we should insert not too deep and to target superficial fat compartment than deep fat compartment. I think sagged tissue is similar to seesaw with pivot point on bone. The plate is loosened retaining ligament. We can cut and release retaining ligament using doing thread lift. For more change of distance with same force, we should force at the farthest from the pivot point. In a nutshell, this patient came into my clinic and she looks sad and complains everything on her face. But maybe she obsessed on nasolabial fold and marionette line. While her monologue, we should scan and analyze her face first. After done scanning, I try to distract her obsessed attention. I recommend to try to distract their obsessed attention to others, especially including contour. Then simplify her problems from 3 or 4. To improve that, I set each target. Now just the way inserting thread is left. There are already many techniques you learned or listened to. All techniques are good, but not perfect. There is no only one right thing. That's because everybody has different sense of the hands. And when I say insert deeply, the depth I think might not be the same to the depth you think. I want you to filter out what I'm saying about technique. Just adjust to you, yourself. Just its recommendation based on my experiences. Tissue has sag to inferior and medial side, so we need the tissue for pull vertically and posteriorly. I prefer multiple entry points. That's because I think migration of inserted threads on fixation point is the main reason to lose lifting effect. So I use 3 points for vertical vector, they're above lateral canthal level, and 1 for lateral vector. To do real thread lifting, first of all, mark zygomatic ligament area to avoid there. Then insert two threads each point. To lift the mollified pad, to target mollified pad, insert at temporal hairline just above canthal level, but not insert too close to nasolabial fold. It means that you don't need to insert the cannula fully. I usually insert the thread until mid-pupil level, and it does not have to be perpendicular to the nasolabial fold. Sometimes I insert reverse direction to avoid the depot complication and to target the compartment accurately. It's easier than forward direction. I use double forte protected by Dongbang, always. Next, I target to lift the middle cheek fat compartment to improve midline line. I use an entry point around between canthus and eyebrow level. Insert one thread to mouth corner and another one to the lower end of marionette line. Two tracks are usually below zygomatic ligament area. At the level of eyebrow or a little higher, insert one thread vertically and another one to mandibular angle. A lateral vector pulls the tissue with a spiral vector. It may feel a little unfamiliar, but this works well to gather tissue on some small area. The area is mid-face. In severe marionette line cases, I insert two threads from just posterior ear lobe to marionette line. At this point, you should take care not to penetrate parotid gland. For that, before insert thread, make proper tunnel with 18 gauge needle. If we put it all together, you can see multiple threads overlap each other. I think they disperse the tension on fixation point each other, and it prevents migration from fixation area. In addition, the most overlapped area is around the zygomatic arch. I think that this crisscross technique can make new hard retaining ligaments on zygomatic arch to replace loosened ligaments. It leads long-lasting effect, I think. Okay. Today's my last part is indication for thread lifting in Asian face. As you already know, skin laxity is one of the most important criteria for thread lifting. Fat lifting is not effective to patients who have moderate to severe skin laxity. This paper says, and as we already know, Asian has thicker and firmer skin than Caucasian does. So we can think that fat lifting is more appropriate to Asian than Caucasian. We can see moderate to severe skin laxity on the right side women with moderate degree of fat deflation. Right side patient has mild skin laxity and minimal fat deflation. I proceeded fat lifting both. Can you predict who will get better fat lifting effect? It may be easy, I guess. Almost the doctors said about the thread lifting indication like this. All changes should be mild. Especially patients who want the thread lifting should have enough fat volume to show a dramatic change. Based on this concept, we can predict that right side patient will be good by thread lifting. But how about the results? Is it matching to your prediction? I think both patients are good. Left patient obtain more changes, of course, but can we say right patient get bad result based on the previous indication? So I want to say, yes, there's better case for thread lifting also. I totally agree with it. But I also think there's no limitation than what we think. Just give you a shot to everyone who gets order. You can make it and can find new way to improve that. Real lastly, I'll just briefly tell you about the patient that should be avoided relatively. This patient got thread lifting procedures multiple times. As you can see, her facial line is not bad. There's just a remnant skin, especially around the mouth corner. This patient is not good indication for thread lifting. This patient should be got an invasive surgery for me to remove the remnant skin. It's similar to wrap something tightly. Post-operative result. Is her facial outline changed much? No, not much. Most of the result come from tightening the skin by resection. So checking history is very important to avoid like this patient. Okay, today's presentation